So, two things. You have to excuse me. I'm going to use some notes. As you can tell from the speakers before me, I kind of stand among giants up here, so a little bit of nerves. And then you're never too old to be embarrassed by your mom. So I'd like to thank my mom for being here today, and not only doing that, not sitting with my boss, but sitting with my boss's boss, all the way at the top in the back row. Okay, so I want to talk about ICU care. So we know that the only constant is change. And in medicine, everything changes all the time. So this is a conference paper written by my grandfather in the 1960s. And he was writing his notes. And in his notes, he wrote two things. So he was an anesthetist with a special interest in neonatal ICU. So the first thing was, now this is 1966, I think. The value of intragastric oxygen has at last been discounted by Lucas. They were using intragastric high-flow oxygen to resuscitate neonates in the 1960s. That's only 50 years ago. But he's adamant still that drugs are quite illogical when injected anywhere but into the heart, as the circulation is often almost at a standstill. So what's the point of telling you this? I'm hoping that in the 10 minutes that I stand up here to change the way that you think about the meaning of ICU care and to persuade you that change is good. And that you can do it with the little bit that you have, and that it's not about cost, that there's lots of low-cost parts of ICU care that are important. ICU beds are a scarce resource and expensive for hospitals, and we've all had a frustrating situation where you've been stuck with a critically ill patient who cannot access the care that they need in an ICU. So whether you're a paramedic who's fetching a patient who's been stuck in a peripheral hospital for hours, maybe days, or an emergency doctor or nurse who's been desperately trying to care for a patient who there is no ICU bed for, this means that you've already done critical care, you've treated a critical patient, and you're part of the chain of critical care. And no part of medicine is an island, and there's a lot of fancy and expensive things that they do in ICU that don't apply to us, but there are a lot of low-cost things that we can do. So what is critical care? It's not a place. It doesn't have four walls. It's a concept. And it's a way of treating patients that gets them better as soon as possible. So why do we care about that? Because medicine is about caring, but it's also about outcomes. And sure, those are measured in different ways by different people and places. Hospitals love numbers. They love to be able to measure patient outcomes and cost and mortality in statistics. But a patient measures their outcome in the time they spend away from their family, their loss of income and the expense of being ill, and their long-term health. And how do we measure things? Well, we like being really good at what we do, right? And I know that you like that because you've given up an entire Saturday to come sit here with us. So up until now, a patient's outcome may have been dependent on how long they had to wait for an ICU bed. My proposal is that we take aspects of ICU care to them that's going to get them home faster, and that's what critical care is. So in South Africa, we know that a lot of our patients are immunocompromised already, and specifically in pediatrics, the bulk of ICU admissions are secondary to an infection of some kind, mostly pneumonia and gastroenteritis. In the developing world, hospital-acquired infections are far, possibly as much as triple, that of those in the developed world ICUs. So the challenge for us is real. So I hate statistics. I think that if you're learning, you get bombarded with statistics. So I was going to explain this to you in blocks of 10 people. But the problem with people is that they're a bit of a mixed bag. So there's some that, you wouldn't mind if it was like a 30% non-survival rate. So instead, I wanted to explain it in superheroes. So if 3 out of 10 superheroes got a hospital-acquired infection during their ICU stay, and that doubled their ICU stay, who would be defending Gotham City? And who would squirt little webby things? I don't know. So and so we know that an ICU is a more controlled environment, and there's a lot of data for hospital-acquired infections, but there's none for pre-hospital-acquired infections. we know that an ambulance isn't exactly a clean place, and I think that probably the first thing I learned before I even got on an ambulance was to never mess with the business end of an ambulance mop. But that mop touches your ambulance. So all we can, as medical people, we can be involved in breaking the chain of infection, of saying, yes, when I went to the guys at Kurtzkia and asked them, the ICU guys, so if you had 10 minutes to talk to people about the ICU care they think they could deliver in the emergency department, what would you tell them? And they were like, we would tell them to wash their hands. And I was like, well, that's not very sexy. So I want to talk to you about ventilator-associated pneumonia instead. So internationally, there's a wide variety of definitions and criteria, and no one can, as with most things in medicine, seem to agree on anything. But we can agree on two things. It's pneumonia, and it's caused by a ventilator. So in developing world ICUs, we have a very high incidence when compared to developed world ICUs. And this is possibly to do with our disease profile. And then I didn't know if you were going to care about superheroes a lot, but I was pretty sure that everyone cared about puppies. So, yeah, guys, sorry. There's not a lot of consensus about these mortality statistics, right? But best care always estimates mortality from ventilator-associated pneumonia between 2 and 7 puppies. And I don't know about you, but that's not good enough for me. I got a little emotional making these slides, actually. Okay, so when I started talking to them about ventilator-associated pneumonia, they said that they believed that one of our greatest crimes against critically ill patients was the way that we intubated them. So my lovely assistant Katja did me the grand favor of going to an emergency department in Cape Town this morning and collecting this laryngoscope. So who in this room, by show of green cards, would lick that right now? It's been cleaned in the normal method, sink, bioscrub, maybe a little bit of towel. Yeah, no one, right? Who would do that? Okay, so this, and then I, personally, this is my laryngoscope. Can't remember when last I used it. I keep it in an airway pouch. I probably cleaned it in a sluice room in an emergency department. Anyone want to lick that? No, I don't think so. Well, you missed out because there was going to be a prize if you would. I'm joking. I wouldn't let you. Okay, so let's think about the way we intubate people. You're in an emergency department. You've got this critically ill patient. Someone's arguing with you from over there. You're like flicking desperately through the drawers. So and now you can't find a laryngoscope blade and everything's going wrong. You've dropped the suction catheter on the floor, but who cares? And you're going to pick it up and you're going to use it again. So this is probably our greatest crime against patients, is the infections that we introduce into them. Because that's what we're actively doing if you're doing that. Think about where your laryngoscope is kept. So you've cleaned it in the sink somewhere, maybe using bioscrub, not good enough. You're putting it in a drawer, which is not sterile, not good enough. Maybe you're a paramedic. I mean, I once intubated someone who had just recently eaten fish, and I swear that smell didn't go away. I tried, I actually threw the blade away. And then, so you're a paramedic, you clean the blade, you put it back in a non-sterile airway pouch, and put it back in your ambulance. It's a whole series of possibilities for infection that we're just complicit in. So what I'd like to encourage you to do is to think very carefully about the way you clean things and the things that you are doing to a patient. The standard you walk past is the standard you accept. Stefan said it earlier, and I think it's a really important thing. If you're sitting here, you know that you're not alone amongst a group of people who are actively trying to make emergency medicine better and practice better medicine. Thank you.